Hello and welcome to the second part of my lecture. We are covering blood transfusion reaction and autologous blood transfusion and RH incompatibility. So, what are the blood transfusion reactions? First and foremost, it can be infectious, viral or bacterial, but these are not commonly seen because we are doing transfusion transmitted infection testing. Okay, TTI testing as we learned in earlier lecture. The other reaction is non-infectious, in which there are mainly three categories. First is reaction to RBC antigens, that is acute hemolytic transfusion reaction and delayed hemolytic transfusion reaction. Second is reaction to donor proteins, that is minor allergic reaction and anaphylactic reaction. And third is white cell related transfusion reaction, that is febrile reaction and transfusion related acute lung injury, that is TRALI. So, what are the causes of transfusion reaction? So, first and foremost cause is clerical error. So, inadequate labeling of the sample or blood bag can be there. Wrong blood might be issued. There are certain technical errors like error in blood grouping and cross matching. The interpretation of test results can be incorrect, or others like blood contamination during phlebotomy, blood infusion through small bore needles, the blood which is less than minus 30 degrees or warmed to more than 42 degrees, and concomitant administration of blood and drugs through common site. Okay, so these are the few common causes of reaction. So how will we prevent errors in the transfusion chain? Okay, so first and foremost error is sample error, then it will be technical error, it might be due to wrong blood issued, storage error, patient misidentification, and administrative error. Okay, so first we should identify who is making this error and why the errors are occurring. Okay. For example, if I tell you sample error, the samples are collected in ward. So if there is continuous sample errors happening, the person who is responsible for blood collection in the ward should be notified and the sample error can be prevented. So if we classify it in acute and delayed, the acute can be further classified into immunological and non-immunological, and delayed can be further classified into immunological and non-immunological. So, if you see acute transfusion reaction, it can be hemolytic or it can be febrile non-hemolytic transfusion reaction, that is FNHTR. It can be allergic reaction. It can be TRALI, that is transfusion related acute lung injury. It can be coagulopathy with massive transfusions or bacteremia. Okay. So these are the acute transfusion reaction. First is febrile non-hemolytic transfusion reaction, that is rise in patient temperature of more than 1 degree centigrade associated with transfusion without the other fever precipitating factors. So other fever causing factors should not be there, but it is associated with transfusion, rise of temperature of more than 1 degree centigrade. Its onset is during or within 4 hours following the transfusion. It is mainly induced by cytokines and occurs with approximately 1% of packed RBC transfusion and approximately 20% of other platelet transfusions. Okay. So again, important thing is onset is within 4 hours. Temperature should be more than 1 degree, not with other precipitating factors. Most commonly, 1% of packed RBC transfusion or 20% of platelet, it can be seen. So this is mild, moderate, and severe. Further classification. Mild is unexplained fever. Temperature is at least 1 degree but less than 1.5 degree. And there is absence of chills, rigors, respiratory distress, and hemodynamic instability. If we come to moderate, but the temperature is at least 1 degree centigrade raised, but it is not meeting the criteria of mild or severe. And in severe, the fever is more than 39 degrees centigrade, temperature rise is more than 2 degrees centigrade, and there is presence of chills and rigors. So first and foremost thing you should do is stop the transfusion, check label and recipient identity, check whether the person who is receiving blood is meant to receive the blood, same blood. Okay. Slow the transfusion if reaction is mild, and the medical officer if it elects to continue transfusion. But in our facility or in our setup, any if any of the reaction occurs, mild, moderate, or severe, the transfusion is stopped. We will be giving antipyretic paracetamol. I monitor closely. Steroids are not given in minor reaction. Coming to acute hemolytic transfusion reaction, it occurs when incompatible RBC are transfused into the recipient who has preformed antibodies, usually ABO or RH. So one example hypothetical I can give you is if the person is having a positive blood group, so his serum will be having anti-B antibodies, and if he is transfused B positive blood, the transfused RBC which are having B antigen will be reacting to the antibody anti-B which are present in recipient serum, and acute hemolytic transfusion reaction can occur. Okay. How this occurs? These antibodies activate the complement system, causing intravascular hemolysis of RBC. These symptoms occur within minutes. Okay. The most important thing is within minutes. In febrile non-hemolytic, it can occur up to 4 hours, but in this, it occurs within minutes. The hemolytic reaction can occur with as little as 1 to 2 cc of RBCs. Okay. And in this, labeling error is the most common problem. The labeling of the blood group of the donor blood bag is the most common error in this, and it can be fatal. The signs and symptoms are the recipient will be having fever, chills, rigors, nausea, vomiting can also be there. If there is massive transfusion, hypotension and tachycardia will be there due to bradykinin. The patient will be flushed and dyspneic due to histamine. There will be chest and abdominal pain. There will be headache. There will be hemoglobinemia, hemoglobinuria. There may be oliguria with acute renal failure. There can be jaundice due to bleeding due to DH. First thing is stop the transfusion. It is same in each and every reaction. Check the label and recipient identity. Replace the IV site and start normal saline so that whatever blood is in the vein or anything, it will be dissolved. Treat the shock and maintain blood pressure with saline. Investigate possible DIC and treat significant if significant bleeding is there. Diuretic also can be given if urine flow is low. Steroids can also be given to reduce the immune mediated effects. Okay. Then samples to be taken to assess renal and liver function. Okay. Full blood count is done. Bilirubin is also done to assess the liver function. Okay. Urea grade is done to check for renal failure. And the hemovigilance notification is sent to blood bank. So this all is done in the ward. Okay. And they'll send us the notice to blood bank that this kind of reaction has happened and you need to check the blood. Coming to delayed hemolytic transfusion reaction, the onset is usually 1 to 7 days post transfusion but can be up to 28 days. Okay. So what happens in this is there will be worsening anemia and jaundice from destruction of red blood cells. It is often asymptomatic, but in some cases splenomegaly, hemoglobinemia and hemoglobinuria can be seen. Renal impairment is seen in severe cases. So what we should do in this cases is we should do hemolytic investigation. Okay. So full blood count is done, peripheral smear is checked, direct Coombs test can be done. Okay. And blood group antibody screening should also be done. In some cases in which there is jaundice is severe, we can also undergo liver function test. Okay. Now, allergic transfusion reaction, that is very minor. Okay, frequency is 1 is to 100 to 1 is to 5, but they can be easily managed. So that's why they are not that severe. So most commonly seen in plasma and platelet transfusion. It occurs within 4 hours of transfusion. Recipients may be having antibody which is reacting to the antigen in the transfused product. Okay. So as I told you, it is a not that severe reaction. It is minor or localized reaction. The skin will be flushed. There will be rash formation. Can be urticaria present. Some periorbital edema or itch can be present. Minor edema of lips and tongue can also be present. Again, management is slow transfusion, but we are doing not slowing. We are just stopping the transfusion. Or if it is very localized, very few symptoms, we can give antihistamine like loratadine or cetirizine. Okay. If the symptoms are mild and transient, transfusion may resume, but it is done at a slower rate and with BP and temperature monitoring. Okay. Again, send the hemovigilance notification to the blood bank. If the symptoms increase, stopping the blood transfusion. So this is we talked about mild reaction. And sometimes it is moderate reaction. Moderate માં શું થશે? Coughing will be there, hypotension will be there, tachycardia will be there, dyspnea, Sills and Rigers. Okay. Management is stop the transfusion, check label and recipient identity, replace the IV site, same as I told you earlier. Give saline, then give antihistaminic, give IV fluids, give oxygen, also maybe giving steroids. Okay. And the last is severe or anaphylactic allergic reaction. In this, there will be antigen, there will be antibody which is reacting with the plasma protein in the blood component, IgA or haptoglobin. There will be life-threatening symptoms. Okay, so all the moderate symptoms will be there. Also, there will be life-threatening symptoms like severe hypotension, shock, tachycardia. The whole body urticaria can be seen. Wheezing, stridor, change in voice, so laryngeal edema can be seen. Anxiety can also be. Stop the transfusion, check the label and recipient identity, and follow anaphylaxis guideline. First, give adrenaline and repeat at 5 to 10 minutes if interval required. Replace the IV set, give saline, consider giving steroid, giving antihistamine. Okay. Sedating antihistamine is contraindicated because the patient is having laryngeal edema. If he is having sedation, there will be huge respiratory problem. Now we are going to see transfusion associated lung injury, that is TRALI. Okay. The frequency is less than 1 is to 5000 and onset is within 6 hours following transfusion of plasma or plasma containing compounds. So it is a group of disorders which is clinically indistinguishable from ARDS, that is acute respiratory distress syndrome. But one of the recognized mechanism involves the donor antibody reacting with recipient neutrophil or HL antigen, causing cell activation that results in acute severe microvascular lung injury. Okay. So the antibody will be present in the donor, and when transfused in the recipient, it activates the neutrophil and it will be leading to acute severe microvascular lung injury. Okay. So the onset of severe dyspnea and cyanosis, ultimately leading to respiratory failure, bilateral infiltrates on X-ray within 6 hours of transfusion. But there will be absence of left atrial hypertension. Okay, so there might not be circulatory overload, and it should be distinguished from ARDS or cardiovascular overload. Okay, management is intensive care management for respiratory failure. Diuretics are not usually helpful. This is coming to TACO, that is transfusion associated circulatory overload. Why this happens? Whenever there is rapid onset after effusion of a volume of fluid that is clinically significant. Okay. So, in what scenarios design? So, in if the patient is a baby, small baby, neonate or 1 to 2 months, and if we are giving him or her 300 ml blood, so it will be clearly circulatory overload. Or if the patient is elderly, having impaired cardiovascular state or renal impairment, again, if we are giving him or her huge volume of blood, TACO can occur. Okay. One important factor is also if the infusion is too rapid. Okay. Fast infusion or high volume infusion, it can be leading to TACO. Clinically, it will be leading a significant symptoms will be like acute heart failure, and it can be prevented by slow infusion rate and volume of transfusion according to the need. The blood pressure will be increasing, pulse is rapidly bounding, respiratory stress can be seen, GVP is increased, pulmonary edema can be seen. In management, directly stop the transfusion, give diuretic, recipient upright with legs over side of the bed. Okay. So the difference between Trali and TACO. So blood pressure is low or normal in Trali, but it is increased in TACO. Chest X-ray, no congestion is seen in Trali, but vascular congestion, pleural effusion is seen in TACO. Ejection fraction is normal in Trali, it is abnormal in TACO, and response to diuretics is inconsistent in Trali, but very much improved in TACO. One other type of reaction is bacterial contamination or bacterial sepsis. It is more common and more severe with platelet transfusion. Why? Because they are stored at 22 to 24 degrees centigrade. Organisms can be gram-positive organisms like staph or strep, or if the RBC are transfused, it can be Yersinia or Enterobacter. The symptoms can be chills, fever, rigor, shock within minutes after transfusion, respiratory distress, laryngeal edema, in the arm in which it is transfused, it will be paining, there will be chest and back pain. The treatment is giving antibiotics, a broad spectrum penicillin or cephalosporin, and gentamicin to cover all the organisms. Okay. So cooling. Okay. Cooling is like the body temperature will be rapidly decreasing. When this will happen? This will happen when there will be rapid infusion of large volumes of cool fluid. So, for example, FFP is stored at minus 80 degrees. We thaw it, okay, it is fine. But if it is transmitted to the ward and if it is stored in the fridge and then it's taken out and transfused, the temperature of FFP can be 2, 3 degrees, 4 degrees. And if it's transfused in a large amount, it can lead to decrease in the body temperature. Okay. It can be leading to cardiac rhythm irregularity. The main thing which we should take care to prevent this is to not use cold fluids. Check the proper temperature. The ideal temperature should be room temperature or body temperature. Okay. Now coming to chronic transfusion reactions, that is alloimmunization, transfusion associated graft versus host disease, iron overload, TTI, that is transfusion transmitted infection, and post transfusion purpura. Okay, post transfusion purpura is it is seen after 5 to 12 days of transfusion. Severe thrombocytopenia can be seen with purpura and possibly other bleeding. This will persist for 1 to 2 weeks. In this graft versus host disease, the product which is transfused, it will be acting against the body, the recipient's body, it will be causing CVHD, that is graft host disease. The general management of acute reaction is, if it is mild, you give antihistaminic, okay, and if it is somewhat moderate, you stop the infection, stop the transfusion, okay, mild slow the transfusion, give antihistaminic. Moderately severe as I told you, signs and symptoms, this is clearly stop the transfusion, give antihistaminic steroids. In life-threatening reactions such as intravascular hemolysis, TRALI, fluid overload, anaphylactic shock, so signs will be fever, shock, tachycardia, pneumonia, DIC, symptoms will be chest pain, respiratory distress, stopping the transfusion and giving the according treatment. Coming to second part, that is autologous blood transfusion. So there are two types of major blood transfusion. Autologous is the reinfusion of blood or blood products taken from the same patient. The donor is same, recipient is the same person. And second is allogenic or homologous blood transfusion. The transfusion of blood taken from a donor to a recipient is called allogenic or homologous blood transfusion. So autologous blood transfusion is not a new concept. Okay. Why it is growing now? Because there is a constant fear of transfusion diseases, and autologous blood transfusion clearly prevents that. It was employed as early as in 1818. Reinfusion of blood was employed in 1818, and pre-operative donation was advocated in 1930s. Blood salvaging was reported during neurosurgical and obstetric procedures from 1936, and during the last 20 years, there is constantly increase in the use of autologous blood transfusion. Due to the technological advances, the use of ABT is quite safe, and now the reinfusion and recovery of the blood is quite easy due to technological advances. What are the advantages of autologous blood transfusion? So it can avoid many complications associated with allogeneic transfusion, such as all the acute hemolytic reaction, all the allergic and febrile reaction, the transmission of diseases. There will be avoidance of immunosuppressive effects of allogenic transfusion. And if the patient is having any rare blood group, they can be very advantageous. For example, if I tell you the Bombay blood group patient, there are very few Bombay blood group donors, right? So in those cases, this autologous blood transfusion can help. Also, it allows the availability of fresh whole blood for transfusion. So there are mainly three different techniques: preoperative blood donation, acute normovolemic hemodilution, and intra and postoperative blood salvage. Okay, we'll be seeing one by one. So donor selection for all types, it can be considered before any elective surgical procedure in which significant blood loss is expected. It can be the donor can be selected if any patient is with adequate hemoglobin level. In this, it is mentioned 11 gram, but ideally it is more than 12.5 grams. The patient should be weighing 50 kilograms. The HCT should be more than 33%. That's so that he or she can donate 450 ml of blood safely. Okay, but if the person is having low weight, he or she can give low volume. Okay, adolescent, children below 10 years, elderly also can be a candidate. Obstetric patient can also be a candidate. And history of hepatitis B or AIDS is not a contraindication for blood transfusion reaction. History of hepatitis B or AIDS is not a contraindication for autologous blood transfusion. So first step is preoperative blood donation. So the pre-donation usually begins with 4 to 5 weeks before the proposed surgery, depending on the number of units required. Usually, one donation per week is done. 5 weeks, we can have 5 units of blood, and maximum there will be one transfusion for 3 days. Okay. To prevent the anemia due to donation, iron tablets are usually prescribed. There are no special complications, and the time interval between the last donation and the surgery should be more than 72 hours, that is 3 days. Okay. So, leapfrog technique is used. Okay. So, what is leapfrog technique? It is used when there are 4 to 5 units of blood are required and need to be stored in liquid state. Okay. The schedule usually starts 1 month prior to the surgery and goes on for weeks. So, on day 0, we'll be collecting the unit A. On the day 7, we'll be collecting the unit B and C, but we'll be reinfusing the unit A. Okay. Now, on the day 14, we'll be collecting 2 units D and E, but we'll be reinfusing unit B. So we'll be having 3 units C, D, and E. On day 21, again same. On day 28, again same. So ultimately, we'll be having we'll be having 5 units left to transfuse if needed in the surgery. Okay. This is very important in what? There are certain major surgeries in which the blood is almost always required, such as modified radical mastectomy or Whipple surgery for pancreatic cancer. Almost 3 to 4 bottles is required. So in those cases, this is very helpful. This is leapfrog technique. Okay. The storage of blood, it is separately labeled as autologous. AB or RH is done. Screening for hepatitis B, AIDS are not mandatory. Again, you should remember it is not mandatory. Cross matching is not required. If CPDA is used, it can be stored for 35 days. And if the plasma is separated and serum is used, it can be used for 42 days. Okay. So the main thing you should remember is the availability of pre-donated blood is not an indication. Okay. Whatever blood is unused, it should be discarded, and after proper screening and cross matching, it can be used for other patients. Not commonly practiced in our country. Unused blood is commonly discarded. The complication can be volume overload, sepsis, and transfusion of wrong blood due to clerical error. Coming to second type, that is acute normovolumic hemodilution. In this, refers to the removal of blood from the patient immediately before or just after the induction of anesthesia and replacement with fluid. So no pre-donation is done and the lost volume is replaced by crystalloid or colloid. Okay. So the amount of blood which is collected, it depends on the patient's blood volume and the preoperative hemoconcentration. Okay. So volume is estimated blood. The volume which is collected is estimated blood volume into hemoconcentration minus hemoconcentration the actual and hemoconcentration lowest. Okay. Collected blood can be stored at room temperature up to 4 hours at 1 to 6 degrees for 24 hours. The blood is reinfused in the reverse order of the collection. The first unit which has the highest hemoconcentration, the most clotting factors is administered last. The last which is collected, it is administered first. What is the physiology of acute volumic hemodilution is whenever there is withdrawal of blood and it is replaced by crystalloid and colloid, it will be leading to drop in hemoconcentration, arterial oxygen content, and blood viscosity. It is increased cardiac output and decreased peripheral resistance. So oxygen delivery is not affected, heart rate, blood pressure is unchanged. The advantages, it is very simple and less expensive, provides fresh blood for transfusion, there is no biochemical alteration associated with storage, The removed blood is kept in room temperature, so no chance of hypothermia. The platelet function is also preserved. The oxygen carrying capacity is not reduced, and RBC loss during surgery is less. It is diluted with crystalloid and colloid. Okay. It is possible for surgeries. What are the complications? Myocardial ischemia can occur, hypoxia can occur. Okay. And contraindications are if the patient is having less than 11 gram hemoglobin, less than 33% hemo concentration. And some of the relative contraindication are decreased renal function, severe coronary artery disease, pulmonary dysfunction. And one of the indication is cardiac bypass. Coming to third autologous transfusion, it is intra and post-operative blood salvage. So in this, with the use of special equipments, the blood is collected from operative fluid and draining sites. Recovered blood is mixed with anticoagulant and collected in a reservoir using a filter. The filter blood is then washed with saline so that extra antigens are removed. The RBC that are suspended in saline that are then pumped into a reinfusion bag. When washed with saline, most of the WBC platelet cell fragments are removed and then the blood is transfused to the patient. The characteristic will be the processed blood hemo concentration will be 50 to 60%. The oxygen transport properties in survival of RBC are equal or superior. The processed blood has high 2-3 dpg levels, so oxygen transportation is more, and the pH is. What are its application? The major application is if the blood loss is more than 50% expected, if the patient is having rare blood group, or like elective or emergency surgeries like cardiovascular surgery, liver transplantation, neurosurgery, ortho operations. Complications can be so many: air embolism, fat embolism, sepsis, renal dysfunction due to presence of free RBC and fragmented RBC. Summary. So for the types, there are mainly three types. Okay. Advantages of autologous transfusion. You can clearly see all the reactions are not present, or the reaction which can be seen in allogenic transfusion are not present in autologous transfusion. Leapfrog technique, as I told you, you collect 2 units, transfuse 1 unit, collect 2 units, transfuse 1 unit. Do it every week for 5 weeks. Acute metabolic hemodilution, intra and post-operative blood salvaging use of. These are the. Now, one important thing you should know is RH incompatibility, very commonly seen and asked also in gynecology and in pathology. So, what is RH factor? There are proteins or antigens which are occurring only on surface of RBC. If the proteins are present, it is RH positive. If the proteins are absent, it is RH negative. So, according to that, the blood groups are given positive or negative. Okay. Why RH factor is important? It is most important for pregnancy. The inheritance is autosomal dominant and 15% is RH negative. But remember one thing in mind, that antibody to RH antigen is not naturally present. If you see the ABO blood group system, the antibodies are naturally present. The patient is having A group, the antibody B will be present. But in RH, if the patient is RH positive, there won't be any anti-RH antibodies present in the blood. Okay. So introduction is, whenever during the pregnancy, the mother and fetus will be having different blood group, different RH protein factors. This condition is known as RH incompatibility. Okay. Directly, it does not affect the health, but it is very important during RH antibodies are formed. Then it will be it will be going whenever there is second pregnancy occurring and the baby is RH positive again. These antibodies can cross the blood placenta barrier and cause the hemolysis of baby RH positive RBC. So, what are the sensitizing events for rhesus disease? It can be miscarriage, it can be abortion, it can be antepartum hemorrhage, or it can be invasive prenatal testing, the amniocentesis, delivery, or ectopic pregnancy. So, what is the progression? As I told you, whenever there is sensitization, the antibodies are formed. If the titer of antibodies 1 is to 8, it indicates sensitization and it requires titer monitoring. And if the titer is more than 8, it is possible that the fetus will be damaged and fetal monitoring should be done. So, what we do in our blood bank is if any of the female is having negative blood group, we ask for the history. And if the previous baby is RS positive, we'll be doing the antibody titer from mother's blood. If it is less than 1 is to 8, the sensitization is there, but it is not that significant. But if it is more than 1 is to 8, any fetal damage can be seen, so fetal monitoring should be done. Same as I told you, this is the same slide, you don't need to go into detail. Causes, as I told you, it is can be due to ectopic pregnancy, antepartum bleeding, platelet transfusion, placental abruption, abdominal trauma, fetal death, okay, prenatal care. One important cause is lack of prenatal care. Why? Because most of the female which are in rural areas don't even know their blood group. So this is one of the important cause. Okay, they don't know their blood group. The first child is coming positive. For one or the other reason, the delivery is in home delivery. So no blood group is done of the baby also. And in the second pregnancy, there will be hemolytic reaction. Symptoms, it can cause mildly, it can cause secretion of red cell, and deadly, it can cause fetal death. If the infant survives, he or she can be having jaundice, hypotonia, lethargy, swelling or edema can be. There will be signs of fetal anemia due to restriction of RBC, that is polyhydramnios and the fetal heart, ascites and pericardial effusion. This I am talking about intra-utero. Okay. Reduced fetal movement, abnormal cardiotocography which reduce variation. Diagnosis is via MCA Doppler, amniocentesis, that test. So screening test is well, most important is screening test. Okay. Whenever the lady is visiting for his first prenatal visit, EBO and blood grouping is done. If antepartum or postpartum bleeding occurs, give her immunoglobulin NTD, okay, and check the neonatal blood. We can also do direct and indirect womb test too. You don't need to go into detail because you already learned direct womb. There are certain ultrasound parameters, but they are non-reliable. The size of the umbilical vein, placental thickness, hepatic size, but they are non. Complication is management. Give NTD immunoglobulin to the mother. Give fetal blood transfusion if it is detected intra-utero or after delivery. Phototherapy can be. So how will you do fetal transfusion? We'll be inserting a needle in the umbilical vein and blood is transfused and checked continuously via ultrasound transducer. The transfused blood should be RS negative, cross-matched with the mother sample, and densely packed RBC are given. White cell and platelets are removed. Or prophylactic vaccination during every pregnancy, after a miscarriage or abortion, or prenatal tests such as amniocentesis and pulmonary biopsy is